Let's remember 1, 2, 3, 4, 5 things that will present great difficulties when we try to perform DNA diagnostics. Number 1, clinical heterogeneity. Identical mutations in the same gene give a spectrum of clinical diseases, enough to consider them as separate disorders? Mostly not, but in some cases, maybe yes. Clinical heterogeneity. Different clinical presentation, identical effect. Allelic heterogeneity, very well documented in the literature. Different mutations in the same gene giving slightly different clinical characteristics. Third, genetic heterogeneity. Identical clinical characteristics, different gene involved. So the age where the clinical geneticists had to guess what gene might be affected so we can target the molecular testing in that gene is gone. Because the more we learned about our DNA, the more this became evidence. Fourth, penetrance. Overused concept. We use it to justify everything. I'm totally against it, but it exists. What is the penetrance? It's that the probability that of the presence of a genetic variant will also cause clinical characteristics. So, you see a variant in a child that matches the phenotype, and the father has the same variant but doesn't have the clinical characteristics. So, you say to yourself, is this responsible for the disease? And if this is responsible for the disease, how come the father doesn't have it? Well, penetrance. I think it's overused, but I cannot deny that it exists, and it has been demonstrated. Finally, mosaicism. We do not have only one cell line in our body. Different tissues have different cell line, and they differ in a few points, not in a lot. But these points are very significant in reproductive options. When I went through school, if someone has an autosomal dominant disease, the risk, and that was a de novo finding, the risk of recurrence we were quoting as very minimal or infinitesimal. Now we know that because of the mosaicism, there could be gonadal mosaicism either in the sperm or the egg that created this person. So the recurrence risk is not small or infinitesimal, and for a de novo variant, we would recommend prenatal or pre-implantation diagnosis for the following pregnancies. Very important to keep this in mind. So, name one disease that all of this play a role. Well, retinitis pigmentosa. This is a disease of the eye where you have cell death of the retina cells, and it leads to blindness progressively. I'm not going to go into clinical details. More than 60 genes involved in this disease. The majority of them, or close to 50% of them, they are unmarked genes. So we have a patient with retinitis pigmentosum, we perform DNA testing for all the known genes, and we don't find anything. All the modes of inheritance, autosomal dominant, autosomal recessive, X-linked, mtDNA. Only for the recessive form, in the pie chart, the recessive only form, 50% of the genes are unknown, and the rest 50%, there are multiple genes involved. So how am I going to guess what gene is involved in order to do the DNA testing? I need to use a modality that will include all the possibilities and take into consideration the allelic heterogeneity, the genetic heterogeneity, the clinical heterogeneity, the penetrance, and the mosaicism. Not an easy job if you analyze it. Well, despite that, we test children, mainly for genetic diseases. We test the parent preconception. We perform NIPT, amniocentesis, CVS, prenatal diagnosis. We test adults, especially for adult onset diseases. We test adults preconception for family planning. Lately, we have been able to test the DNA for predisposing variants to polygenic multifactorial diseases, because there have been algorithms developed that take into account the predisposing DNA variants, the habits and the environment of the specific person, and they assign a risk for certain diseases to these individuals. So preventive action can be, and corrective action can be implemented very early in life, so we can delay the onset of the disease and we can reduce its severity. And of course, pharmacogenomics. You are going to hear a lot about this, Dr. Patrino's specialty, which is response to medication. And it's very important when you need it. If you don't need it, it's not that important, but if you need it, that's when the importance comes out. And lately, algorithms have been developed, because if you tell me you are a slow metabolizer of this drug, or you are a fast metabolizer of this drug, so what good is this information to me? I want to know what drug is more appropriate for me and at what dose. This is the information that the clinician needs in order to manage a disorder, and this is what the DNA can tell them, but then we need to tell them how and how often. So, what do we see in the DNA diagnostics laboratory? What are we asked to do? First of all, the most common thing we see, believe it or not, is whole chromosomal abnormalities. A number of the whole chromosomal abnormalities are associated with maternal age. The more advanced the maternal age, the more the frequency of the abnormalities, and these are the trisomies 13, 18, 21, triple X, XXY, and 45X. Whole chromosomal abnormalities, number one. Number two, partial chromosomal abnormalities, microdeletions, microduplications. They do not depend upon maternal age. Which are the most common ones? They are listed, some of the most common ones are listed here. Are they true? Sure, they are true. They are very true. They do not depend upon maternal age, and they are a flat 1 in every 1,000 pregnancies. There will be a microdeletion or a microduplication. So when I'm talking about DNA testing, I'm not focusing it postnatally, but also prenatally. DNA testing is DNA testing, no matter at what stage of the individual you test it. The 1p36, the 4p minus, the 5p minus, 8q minus, 11q minus, the Prader-Willi 15q minus, the Angelman and the George syndromes are all microduplications and microdeletions. Another thing that we are asked to diagnose are symptoms of disorder, cystic fibrosis, primary immunodeficiencies, especially the Mediterranean region hemoglobinopathies, alpha globinopathies majorly, and in a lesser extent beta globinopathies, Fragile X syndrome, methylation defects, and now the predisposing variants are coming into play. They were not being asked thus far, but now predisposing variants are being asked by the clinicians more and more. And of course, if and when I need it, I need to know the starting determination for the pharmacogenomics. So these are the type of asks from the clinic to the molecular laboratory. Whole chromosomal abnormalities, partial chromosomal abnormalities, single gene defects, methylation defects, pharmacogenomics. These account for about 90 to 95% of the asks. If I'm way off, please tell me. That's our experience in our hospital and throughout my career. Now, so for when I'm asked to perform a DNA diagnostic testing, I need to take into account the nuclear genome, the mitochondrial genome, phenotypic and clinical heterogeneity, and I have decided to perform genotype-driven DNA diagnostics rather than phenotype-driven. Genotype is when I let the DNA tell me what's wrong, and I decide whether what the DNA tells me, the expert decides on that, if that is the offending variant or not, rather than overlaying the phenotype and restricting bioinformatics to only genes that are related to that phenotype. So, what DNA modality should I use when I'm asked to do a specific test? The easy would be if I know the mutation because someone else in the family had it and somehow it was identified. So we'll do single sequencing for a specific targeted mutation or some other modality. In some cases, I need to decide whether I will do a single whole gene, and what gene might that be, who's gonna tell me, or what are the criteria for me to decide. Is it what I specially guessed? Is it because it's actionable? Is it because it's common in the population? Would I do a gene panel where I would take a number of genes, since the technology gives me that ability, that play a role in a specific phenotype and look at only these genes? But what's going to happen with retinitis pigmentosa? If I include the known genes, I'm going to lose a tremendous amount of information. And finally, WGS and WES, which would be the most desirable, but thus far, they have been expensive. And here is where economics come into play. Cost and payment. Who pays? In Greece, DNA testing is not covered by the government. So it's going to be out-of-pocket expense for the patient. Now, a DNA test would cost a WGS upwards of $1,000, sometime all the way to $3,000. For a person that makes 800 euros a month, it's impossible to pay for this test. In Qatar, where I practice, for the locals, we have 2.5 million people, 300,000 are locals, and 2+ million are expatriates that we serve. So for the locals, they are free through the national healthcare system. For the expatriates, they have to pay for it. I work in the hospital, I can afford to pay for it, although it's expensive even for me. For the Indian and the Pakistani that make $200 a month, it's impossible for them to pay for it. And these are the people that have the 6, the 8 children, not 8, 4 to 6 children for sure. And because of the consanguineous marriages, they present with recessive diseases. So most of the people that need it cannot get it because of the expense. I'm not sure what holds true in Great Britain through NHS, but I know that in places like Greece, only the people who can afford it can perform DNA testing or molecular testing. We, as professionals, need to always be very conscious of the pocket of our patients. These are poor people that cannot afford. Hepatitis C, it needs constant molecular monitoring. People cannot pay the price for monitoring hepatitis C by molecular methods every 6 months. So we are at a point where WGS has gone down in price enough to be able to ask for it. A lot of the people cannot pay for it, but it will cover about 90 to 95% of the asks by the clinicians, because whole genome sequencing will call the CNVs, so we'll call whole chromosome abnormalities, it will call microdeletions, microduplications. If you use the correct pipeline, which I'm going to explain what we decided to use, it will call certain trinucleotide repeats, it will call certain, it will differentiate pseudogenes from real genes for hemoglobinopathies, for spinal muscular atrophy, and for autosomal dominant polycystic kidney disease because of the specific bioinformatics scripts. The pipeline that we decided to use, and I heard from Christina that Helix complained that reviewing results from different bioinformaticians result in different variants being identified. So we needed consistency in the calling. So we decided to employ something that has been validated and HAPA accredited. It's expensive, but in Qatar we could afford it. So we decided for every patient that comes in our door to perform whole genome sequencing in the Illumina platform using short to medium fragments with PCR-free DNA documentation, which I'm not very happy about. I would like longer fragments, but I cannot afford it. The hospital cannot afford it. And perform the primary analysis in the laboratory. The data is parsed through a box that contains waffles, hardware, that are embedded with algorithms, software, that's called Dragon. And this Dragon, what it does is it flags interesting areas. Like the trinucleotide repeats will raise a flag. You know something? I see something here that I don't like. You may want to look at this area a little bit closer. It contains scripts to differentiate for certain diseases pseudogenes from real genes. So I can differentiate these differences, and it aligns all this data to the reference genome, and it assigns quality to each whole. So this box is very, very important, and it takes a lot of the guesswork out of the bioinformatician.